Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Hello, everyone. This is going to be a great episode because we have periodontist Dr. Imad Rastakurdar. Hey, Imad, how's it going?
Hi, I'm good. How are you, saying?
Good. I can't wait to learn about all things perio. But first, let's learn about you. Tell us a little bit about your backstory.
Sure. So I went to McGill Dental School. I finished back in 2014. Then I did a year of AEGD in Rochester, New York, followed by a specialty in periodontics in Kentucky. And then I've been working since, and I work around the city in a few offices, and yeah, love what I do, and glad to be here today.
Oh, thanks, Ahmad. So you're practicing in Kitchener, Waterloo area?
So I have an office in Kitchener. I also work out of an office in Midtown Toronto, and there's also one in Mississauga that I work
Oh,
out.
that's great. The
Yeah.
Greater Toronto area. We're lucky to
Yeah,
have you on the episode because we're going to dig in and ask you like
sure,
all the questions. First of all,
absolutely.
the hardest question, we're going to start off with this. Like, what's with the periodontal classification? Like, I know it's been around for years, but I still don't get it. I have my cheat sheet laminated. I have to pull it out every single time.
Yeah,
Ahmad, give
you're
us
not
some
you're not
tips.
you're not the only one. Yeah, even even for us when it first came out, it was pretty complicated. Funny enough, my program director, who passed away unfortunately recently, he's the
Oh,
one who was one of the main authors, Henry Greenwell. So I had a bit of exposure to it when they were coming up with this classification. The whole purpose of this was the fact that there was a lot of new evidence over the past 20 years since the last one. The last one came out in 1999, I believe, by Armitage. So they just wanted to update it. In all reality, it's still very similar to the old one. It's just that now they call it stages, whereas before it was mild, moderate, severe.
yes.
So basically, stage 3 and 4 are equivalent to severe disease. Stage 2 is moderate, and then stage 1 is mild disease. The localized and generalized part is pretty much the same, 30% of the teeth. If it's less than that, localized. If it's more than that, generalized. And then we no longer have aggressive periodontitis. So that's still classified with staging and grading.
Okay.
Yeah.
So if you have like things in different categories, your patient's like hitting every single category in at least one thing, what are you going to do?
So it's basically the worst tooth. That would be your classification. And then you're grading. There's a lot of stuff in that grading chart, but really on a day-to-day basis in clinical practice, what you would look at is bone loss over, let's say, patient's age. So if it's
Okay.
that's the easiest way to calculate it when you want to kind of predict how fast the disease is progressing. The rest of them are a lot of it has to do with research. They're looking at, let's say, inflammatory markers and things of that nature, or if you've had evidence from the past 5 years, clinical data, which a lot of times you don't have because it's a new patient. So
Mhm.
really, you could just go ahead and look at bone loss over the patient's age. That
Oh,
would be,
nice.
yeah.
That's a lot easier. So it's totally okay if I still have that cheat sheet.
Oh
That's
yeah, yeah, yeah.
You're
Every
probably using it too.
I still use it too. Yeah, use there.
Okay, here's another question, another
Yeah.
tough one. Like, you have a patient, you're seeing them every 3 months. They don't need like gum grafts.
Yeah.
So, they're not getting any better. So now I'm thinking, I feel like I did everything I could. Now I'm going to refer to you, the periodontist. Like, what is it that you do differently than what we're doing with 3-month scaling?
Really, we look at if there is active disease, what's the main indication for active disease? There's pocketing, there's bleeding on probing. If they've had bone loss and now it's 2, 3 millimeters, all generalized, there's no soft tissue deficiency, there's no severe recession. That's basically a healthy periodontium. So that's most likely stable disease. It's really hard to predict when the bone loss happened. It could have been many years ago, and then it started being stable for many years after. Because what you have to remember with periodontal disease, a lot of times there are these short bursts of activity that happens in a patient's mouth, which causes destruction. whether it be due to poor oral hygiene, whether it be due to other risk factors such as stress, systemic diseases, and then it remains stable. So if really there's minimal probing and there's no soft tissue deficiencies, then those patients can be maintained on a 3-month schedule.
Oh, that's good.
Yeah. Yeah.
Now, how about those patients who have really good oral hygiene? You know, they're coming every 3 months, but there's like bone loss, and it's like besides stress, systemic
Yeah.
diseases, genetics, like what else is causing that bone loss?
Really, so if it's been consistent, and it's a good thing, patients that come for recall, you can compare bite wings that you've been taking either once a year or once every 2 years. If there's no change in bone loss, and that's telling you it is stable. Right now, the bone loss, when it happened, is hard to say when, but really those are the main factors. There's no magical thing causing that bone loss. The number one cause is inflammation in the periodontium. What causes it? The main risk factors are the ones you just pointed out. Really, there's not much else. Maybe down the road they find other risk factors, but those are the main ones. Number one, poor oral hygiene, obviously plaque. Okay. Systemic factors, systemic uncontrolled diabetes, uncontrolled systemic diseases. Smoking is a big one. Sometimes, well, if they're aggressive brushers, we notice that causes recession. Well, with recession, you also have bone loss. So radiographically, that would show up as a bit of bone loss, but usually that wouldn't be on the mediodistal surfaces. The recession is mostly on the facial and lingual surfaces. But really, the risk factors that you mentioned are the number one risk factors. And if you see that a patient comes into your practice, they have bone loss, you just have to make sure that remains stable. If it doesn't remain stable, that's an indication of active disease, and then that requires treatment.
Okay, thanks. Yeah. Now I'm going to ask you a really tough question.
Yeah.
To be honest here, Ahmad, do you floss every day?
I do. I don't want. I should be flossing more. I should be flossing twice a day, but no, I do once a day. And I know it's hard, especially I also have a lingual wire, so especially patients that have had orthodontic treatment always tell me it's a pain to floss underneath the wire with those floss threaders and super floss and whatnot.
But are you doing that every day? Cleaning under your lingual retainer? Okay.
It's a pain, but honestly, as one of my professors once said, if there's no plaque, there's no disease. So if you take care of that, then you're good, basically.
So how do you get your patients to floss?
You just have to reinforce the importance of plaque control and what it can cause, right? So like we mentioned a bit earlier, if there's plaque, in some patients, don't get me wrong, in some patients, they have a lot of plaque, nothing happens to them, periodontally speaking, because a lot of periodontal disease has to do with your immune system, how your immune system responds to that inflammation. So you might have a lot of plaque around your gum line, around your periodontium, and you don't lose any bone because your immune system is very effective in terms of overcoming that stimulus, whereas in other patients, and periodontitis is very common, so in the majority of population, even minimal amounts of plaque can cause inflammation and gum disease and bone loss. So you just have to reinforce that and tell patients that if that inflammation is not controlled, and it might take a long time, and it's a silent disease, as we like to call it, it's not going to become problematic until it's too late, and then the tooth has to come out. Because if you start having pain due to periodontal diseases, it's because you have a periodontal abscess or it's too late, right? So as long as you can just reinforce that and make them understand how this disease kind of evolves into later stages, there are actually a lot of patients that are, majority are very compliant.
So do you always say flossing, or are you recommending things like water flossers, intradental brushes? Are you saying like, use whatever you want, just clean between your teeth every day?
In terms of home care, brushing and flossing are the cornerstone. If you want to get it fancier, and then you could recommend water floss and other things. But really, if you look at studies, it's just if you're good at brushing and flossing, those are very important. And if you're compliant with your recall cleanings, right? So because there are a lot of studies, this is not made up. There are a lot of studies where they looked at how often those harmful bacteria repopulate around the gum line. They take 3 months, right? So that's why we recommend 3-month cleanings for periodontal patients. because that's the time where those harmful bacteria repopulate the sites.
And like brushing and flossing, definitely the cornerstone, but with brushing, are you recommending power brush, manual brush? Doesn't matter.
I recommend electric with soft brush heads, just because with manual, employing the correct technique is very difficult, even for myself. So with electric, really, especially with the newer ones, you can't even go wrong with them because you just hold it in place. It does its job. And
Mm-hmm.
if you're applying too much pressure, a lot of them stop working. So
Yeah.
that's telling you basically just kind of back off a little bit. So that's what I would recommend. Yeah.
I'm the same. I use the power brush. I use the IO. Actually, the evidence shows that the power brushes are better than the manual brushes.
Yes. Yes. In
So
terms of, yeah.
oh, that's great.
Yeah.
And any tips on how to motivate your patients to improve their oral hygienes besides saying, hey, like plaque is an issue, you have to remove it. Any other tips?
I mean, not really. Like sometimes, like patients that come to me, a lot of them are at later stages of periodontal disease. So by the time I see them, most likely one or two teeth have to come out. So I tell them, listen, if you don't take care of the other ones, it's going to become like these ones that need to be extracted. And the cost of replacing it with implants or even with a fixed bridge is way, way higher compared to if you were to take care of them and come to those cleanings. A lot of patients say, oh, I don't have insurance to cover for my frequent cleanings. But if you add up the cost of those cleanings, it's going to be much, much less than trying to replace those teeth.
Yeah, it's true. When you talk about the money, then it all makes sense. The
Exactly.
prevention always is always the best.
Yeah. Yeah.
Okay, so I'm going to ask you a few clinical questions.
Sure.
So, how about those patients with a subgingival decay? You know, we're doing that subgingival restoration, and then you're like, the base of that restoration is pretty close to the alveolar crest. Like, I know there's a biological width, but can we just like leave that restoration there, or should we do something?
So definitely no, leaving it is not a good option
Okay.
because the body is gonna basically create that biologic width.
Hmm.
But the issue becomes you don't know how predictable it's going to be. Whereas if you do crown lengthening, you know exactly you're going to remove this much bone, this much soft tissue. You know your margin is going to be about 2 to 3 millimeters from the alveolar crest.
Yeah.
If you don't do that, well, when the body starts making that biologic width, it could affect the adjacent tooth. You could start having pocketing. You could have more bone loss and more inflammation. So no, leaving it is really not an
Yeah.
option.
And then you're
Definitely.
going to get like recurrent decay because
Yes.
now it's an area where like plaque is going to
And it's
go.
more uncomfortable to brush and floss there because it's inflamed. So it's
Yeah.
just a cycle. So definitely with those cases. So you could place a temporary restoration and then do the crown lengthening,
Okay.
wait for that to heal, and then do your permanent.
And it'd
That's all.
probably be a lot easier to do that deep subgingival restoration after the crown lengthening.
Absolutely. You have better
Okay.
access, you have more visibility. Your margins are going to be much better for sure.
Okay, thanks. And then how about like with extractions? It seems like everyone's doing like socket preservation after extractions now. Like
Mhm.
when should we do socket preservation? When shouldn't we?
So socket preservation, I do recommend it in the majority of cases. So if a patient tells me within the next couple of years they're not going to have an implant done, they just want to have the tooth extracted, those cases you could argue, well, yeah, we could just extract the tooth. Granted, I would even say if it's an anterior tooth, even in those cases, I would still graft. If it's a
Mhm.
molar, not. Because for anterior teeth, what you have to remember, the reason why resorption happens if after a tooth is extracted, again, basic thing we learn in dental school, all of us, you have PDL. PDL is inserted into what's called bundle bone, which is part of the alveolar bone. So when the tooth is extracted, that bundle bone serves no purpose. That starts resorbing. For anterior teeth, especially the buccal bone, it's just bundle bone. So once that tooth is extracted, if there is no grafting, you're going to have severe resorption on the buccal aspect. And that's why you get those concavities. So
Yeah.
even if a patient is not having, is not thinking about implants in the short term, I would still graft it just because they're going to do a bridge or maybe down the road they decide to have an implant. So it would be best to do it now. But again, like I said, if it's a molar, they say, no, I'm not thinking of doing anything in the next 3 to 5 years. Most likely you can just extract it. Yeah.
Okay. And then how about when you're doing, a lot of extractions, and this person wants like a denture down the road. And after the extractions, you're seeing like all these little bumpy areas, like from the mesial and distal aspects of the extraction site. Should you just leave it and let the bone fill in? Or should you do alveoplasty at the time? Or should you wait and see if you need to do alveoplasty?
So if it's a complete denture, you usually have to do alveoplasty, and you have an immediate denture to use as your reference point. Partial denture, usually I haven't had too many issues just extracting it without doing much. It should kind of resolve itself.
Okay.
Unless you've had to remove a lot of bone to take that tooth out and you've done more damage to the alveolus. Other than that, I don't see an issue in terms of doing an alveoplasty. But for complete denture, you probably have to do a little bit, yeah.
Okay, that's good. Okay. And we talked a lot about perio.
Yeah.
But how about like things like medications? Do you do like low dose antibiotics like Periostat or other agents?
Yeah. So doxycycline. So that's for patients where we term them as recurrent or refractory periodontitis. Those are patients that you've actually treated their active periodontal disease. You've done surgery. They come to their cleaning appointments, but you're still noticing inflammation and bone loss for whatever reason. Those would be patients that you could put on low dose antimicrobial therapy, usually for 6 to 9 months of doxycycline. That would be a good indication, but it's not for every patient. It's usually for those very patients that don't respond to your conventional therapy.
Okay. And do you use any other things like right in the socket for those, those pockets that are still inflamed after,
Yeah, so you could use minocycline
Okay.
spheres. You could use tetracycline strips. There are a bunch of them. So those are good adjuncts as well. But those, like I said, I wouldn't use it for every patient. Those are really for patients that have had surgery, most likely,
Okay.
and will have inflammation and bone loss happening. Yeah.
Okay, good. Okay. And how about other medicaments like mouthwashes? What mouthwashes do you recommend?
Well, I prescribe after my surgeries usually Paradex or
Okay.
Hexidine on a day-to-day basis, and that's because I'm asking them not to brush those areas that I work on.
Okay.
But on a day-to-day basis, really, Listerine Zero. I don't want to again advocate for a certain brand, but
Mhm.
the ones that don't have alcohol usually would be better. Alcohol is not a great addition to a mouthwash.
Okay.
Yeah.
Good. So mouthwash, would you say mouthwash for like everyone who has periodontal disease? Or
I again, going back to what we said, so as long as they're brushing and flossing,
yeah.
mouthwash would be a good adjunct. And yes, if they do have gingivitis even or periodontitis, any mouthwash would suffice. There's really
Okay.
not too much research that would indicate one is better than the other.
Okay. And how about like as a periodontist, what type of like screw ups do you see general dentists doing that you're like, oh gosh, not this again?
No, so far, I mean, I've had the pleasure of
Okay.
working with great dentists, really, and listen, for everybody, you have complications that happen. I see a lot in implant dentistry obviously nowadays
Okay.
because we're placing implants, but that could happen to any of us, so it's not just
Okay. Okay, good. And you have your own study club. So tell us about that.
my study club, yeah, so we meet usually once every month or every 6 weeks, and we cover a range of topics. Usually I present on surgical related matters. I have a prosthodontist that also presents. So we have guest lectures. And we have a website too. So if somebody's interested that wants to look that up, it's OntarioDentalStudyClub.com. So that way they can get more information from there.
And it's virtual. The presentations are virtual, right? Oh, that's
So
awesome.
we have people from all over Ontario. We actually have people from Quebec as well. So
Oh, good. Now, the way we first met was you sent me an email about the new dentist study club and saying things like, hey, I know about the struggles of new
yeah,
dentists.
yeah.
So tell us, Ahmad, what were your struggles as a new dentist?
So you come out with this much debt, and it's always like in your thoughts, and then now you have to look for a job. Obviously, that's stressful just by itself. And then as you start working, besides the financial thoughts in your head, the clinical part, you've been used to having somebody kind of overlooking your work at every step of the way. Then you're on your own. So that's a big change initially. And it's always good to have a good mentor. So I was lucky to have somebody that I could, look up to and learn from. So that would be my advice. So for somebody who's recently graduating, it's always good to see if you can kind of find somebody that you're comfortable working with, that you connect with, that you can learn from them, because that's really important initially, especially when you graduate. But yeah, in terms of the stressors, those were kind of the main ones.
So, how did you find your mentor?
So you have to kind of talk to your professors in school. They probably have good leads that you can get in touch with. Some of your professors might be looking to hire an associate, and then just looking through, the dental associations for any job postings, and then kind of contacting them. And then by just talking to people, you can get a good feeling of if you'd be a good match for each other.
So, did you find your first job through those dental job postings and journals?
No, the first job, actually, I reached out to a periodontist that I kind of had been recommended to. So that's how I found mine. But there were advertisements that I reached out to as well. But it's just, for me, that's how it worked. I just contacted them directly.
And then you talked about the stress of debt.
Mhm.
Like, how did you handle that? Because that debt also affects the way you work, like the way you're treatment planning, because
Yeah,
it's
yeah. So,
sadly, it's like that's all we think about the first year is how are we going to manage that debt?
yeah. So there's a lot of debt, especially now with I can only imagine the current students with the current interest rates. It's probably very, very stressful. But one thing you have to remember, your patients come first. So
Yes.
no treatment plan, no treatment recommendations, whatever you give should not be based off of your financial motives. It should be what's in the best.
Exactly.
And then you basically chip away at it slowly, but you just have to be consistent, show up to work every day, and just remember that you're not alone, and that there's all your classmates, everybody else before you that have had their debt, and they've managed to pay it off. So you'll pay it off. It's just a matter of being mentally strong and obviously managing your budget well, because you start earning money and then you think that you can. I mean, you're going to start spending on stuff that you haven't been using.
Exactly.
As a student, there's a lot of restrictions that you have in terms of spending, and then you come out
Yeah.
earning or spending all that money. Well, you have to prioritize your income in terms of your.
Yeah. Like my advice is to pretend you're still a student and
Exactly.
and
Exactly.
like spend like that. Because
Yes.
don't think, oh, I'm a dentist now. I
No.
can buy the fancy car and go on the nice vacations because you can't. You have a huge debt. And I
Yes.
like how you said patients first.
Yeah.
Because I was thinking so much about my debt that I realized it was leaking into my treatment plans. Where,
Mhm.
if someone would come in with a lot of cavities, I'd think, oh, I'm going to make a lot of money from this person. And then I went, hold on, Sanj, like you shouldn't be thinking about that. You should be thinking, this person needs your help.
Yes.
And so
Yeah.
I caught myself in the first few months of practicing thinking like, I got to change my headspace because even patients were like, do I really need that? Or do you just want to go on a vacation? And I was
Yeah.
so offended, but then I thought, maybe I'm projecting this.
Yeah.
And so I totally changed my attitude. I'm like, I don't care to the point where it's like, I don't even care what the patient pays. I'm going to do what's right.
Exactly. Exactly. Honestly, in the long run, patients see that. Patients are not stupid.
Yeah.
Uh, they realize when you're honest and you're making up stuff. So a happy patient is going to refer more patients to you. So actually, that's going to work in your favor as well.
Yeah, yeah, that's true. And any do you have any useful resources like textbooks, videos, websites that you'd recommend for a new dentist?
So for new dentists, and I would definitely recommend joining a study club such as yours, because you get to be exposed to a lot of different dentists, experience, and also people your age from different backgrounds. Because honestly, what I can tell you from my experience, because I went to McGill, and then I went to Rochester, and then Kentucky. So I went to different kind of dental schools per se. But so I had a lot of people also coming from all over either Canada and the States. They all had different experiences, and I learned a lot from them. And I'm sure they learned from me as well. So that's good to basically join a study club where you have dentists your age as well from different backgrounds, because you guys can learn from each other. In terms of books, I can't really recommend any books per se, but obviously, if you search for any topic nowadays, there's so many books. Personally, I joined my periodontal journals, the American Academy of Periodontology. There's also ones for implants, Academy of Osseointegration. Those have good journals that send me once a month usually. And try to attend those annual meetings if you have a certain interest. So if you're interested in implants, obviously look up the annual meetings for where implant dentists kind of meet, because you could gain some really good experience and get exposed to good CE courses at those conventions.
Oh, great advice. Now, how you're lot I would like to find out how you manage stress, because you can give us some tips here. Come on, Imad. What do you do?
Oh, so obviously everybody has stress on a day-to-day basis. I try to work out as much as possible. Spend time with family and friends. That's very important to me. That really helps me, just get out of dentistry and talk about other stuff, because there are more important things in life than just 2 millimeter margins and
What?
and, so just make sure you have hobbies or interests outside of dentistry, because a lot of times your stress comes from the fact that you're so focused and you have that tunnel vision that the whole world is about teeth and patient's mouth. It's really not. There are more important to just spend time. My advice would be spend time outside of dentistry.
Oh, that's good. Yeah, and not to define yourself only by being a dentist. You're
No,
also like a friend, a partner, a
yes.
soccer player, like all these other things.
Yeah, yeah. No, you're not defined. Your personality or your confidence should not come just by being a dentist. It should come from who you are and what you value and your beliefs.
Yeah, like your characters,
Yeah,
your characteristics, your values. Now, when something goes really badly, like negative patient outcome,
mm.
treatment failure, how do you deal with that?
Um, so at that time, you want to do what's best for the patient again. So you have to
Exactly.
kind of address the patient's complaint. If they're having pain, take care of the pain. Then kind of backtrack, see, was it something that you could have potentially prevented? Every complication is something you can learn from and apply it to your next case. So
Hmm.
you could have changed something, we'll apply it for your next patient. And sometimes, honestly, you do whatever um, you think is right, and things just don't turn out the way you want them to. And that's just part of dentistry. That's part of just any um, profession, even in medicine. A lot of surgical treatments, they don't turn out perfectly.
Yeah.
So have an open mind, and again, just keep the patient in the back of your mind and do what's in their best interest.
Yeah. And don't think of it as a failure. Think of it
Oh,
as a learning opportunity. Be really transparent,
yeah,
apologize,
yeah,
and do what's best for the patient. If the
yeah,
patient sees that you're going to do what's right to take care of them,
yes,
then they're understanding. And sometimes doing what's right is referring to someone else saying, I
yeah,
think you need another person to help you here. And
yeah.
so just being humble, like don't have your ego and blame the patient,
No, 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 yeah,
and you can't blame yourself either, because otherwise you're not going to learn from it. You could say
yeah,
like, yeah, I made a mistake, but don't get so bogged down into beating yourself up, because then you're not going to learn from it.
exactly,
So
exactly. No,
yeah, it's a learning opportunity and a growth opportunity. So don't even use that word failure. And
yeah, that should be out.
you're never going to make that mistake again, which is great.
Exactly, exactly.
Okay, Ahmad, last question. Very
Yeah.
tough. How often do you get your teeth cleaned?
Not as much as I want to. I
Oh, I knew it.
get cleaned often, more often. Uh, but like I try once every 6 months, but sometimes it just doesn't happen once a year.
Oh, oh
Or
my gosh.
once.
You're just like the rest of us. It's like, okay, whenever there's an opening in the schedule, I'll go in, and then it just never happens.
Yeah, no, I know. I'm guilty of that. So I
We
got
have good oral hygiene, so it's okay. It's all right.
hopefully nobody
Ahmad.
opened my teeth recently. We'll see.
Yeah, like what stage classification are you?
I'm hoping I'm in no stage. I'm just hoping it's all healthy, but who knows? We'll see.
Well, thank you so much, Ahmad. You gave us so much
Thank
great advice on perio, about how to manage the struggles of being a new dentist, how to manage stress, and you're honest. And I'm going to feel no shame the next time I pull out the drawer and look at that periodontal classification sheet.
Yeah, no. I could even put it on your wall in the clinic. There's no shame in that.
Okay, all right, thank you. Thanks so much, Ahmad.
Absolutely. Take
Okay,
care.
bye. Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.